Welcome. Appreciate everyone tuning in to our webinar this evening. We're going to be talking about, as was mentioned, prostatic artery embolization, which is a new treatment option for patients with BPH. Just a quick overview of what we're going to talk about this evening. Obviously, we're going to talk about what is BPH, what is PAE. We're going to talk about the PAE procedure. We're going to talk about the procedure in detail, the ins and outs of it, and then I'll run through some questions that I get asked commonly, and then I'll open it up for everyone in the audience to questions, and I'll do my best to answer them. So a little bit of background about this. So BPH, serendipitously not my initials, but benign prostatic hypertrophy. This is a condition that is extremely common among men. It's a non-cancerous enlargement of the gland that more or less happens to everyone, every male with age. Mostly it affects the part of the prostate gland around the urethra, which is the tube that carries urine out of the bladder. As BPH progresses through the years, it can lead to obstruction or blockage of that tube, which results in difficulty urinating, waking up in the middle of the night, having to go all the time, all these symptoms that come along with BPH. Just a nice schematic of BPH here on the sort of screen. Left there is what a normal prostate gland looks like, and on the opposite side is obviously after many years and the gland enlarges, the symptoms and situation of the urethra being narrowed. BPH, unfortunately, is extremely common, and as you get older, it is an unfortunate condition of men of advanced age. Younger guys don't really generally have issues with it. The normal gland is sort of in the 20 to 25 gram range in men in their 20s and 30s, and it kind of gradually increases from there. But men who become symptomatic from it often have an accelerated growth, and they can end up with glands easily in the 100, 200 range. The symptoms are variable. Guys experience this differently, but basically what we're talking about is LUTS, or LUTS, which stands for lower urinary tract symptoms. This is they generally divide these into two categories: a storage and a voiding issue. So storage is when you don't completely empty your bladder, you have too much urine in your bladder and you end up having to go often or frequency, to go in the middle of the night, or nocturia. Things of that nature. And then the actual voiding symptoms are straining, slow stream, splitting, spraying, difficulty starting, stopping, things like that. The general rule is the rule of thirds, where a third of patients kind of remain stable in their symptoms, a third of patients will progress to requiring treatment, and a third of patients will sort of spontaneously improve on their own, just sort of luck of the draw. And another thing to just keep in mind here is that BPH isn't the only cause of lower urinary tract symptoms, which is why you obviously need to have a thorough workup and figure out what exactly is causing these symptoms. I think probably most of our audience and men that are seeking treatment have filled out a scoring sheet like this, or what we call an IPSS, which determines the severity of your lower urinary tract symptoms. And basically the diagnosis of symptomatic BPH is if you have an enlarged prostate gland and you have lower urinary tract symptoms that are significant, then you fit the criteria. Once we've determined the symptoms and the cause, then we can talk about treatment options. But before we get into sort of the more invasive procedural options, most guys will start out with behavioral or medical options, right? So the behavioral options are things like, avoiding in the sitting position, avoiding fluids before going to bed, limiting caffeine intake before bed, alcohol intake, these types of, things that promote urine output in the middle of the night or during the day. We don't want guys, becoming dehydrated. Obviously, we want you, staying hydrated during the day and having, normal fluid intake, but sort of managing this throughout the course of the day so you don't overload and end up waking yourself up in the middle of the night or getting in a position of urgency or frequency. And then there's also medications that can help with that. A lot of guys, by the time they get to me, are already on these medications. They're either prescribed by their primary care physician or their urologist. Basically, just medications to sort of help open up the urethra. There's various medications, adrenergic agonists, things like this, that will help with these symptoms. Unfortunately, I find that most patients, by the time they get to me, either are having significant side effects from these medications, or the medication simply is not effective. I also find that there's a lot of guys in the boat that just don't enjoy having to take a pill every day. And so, are looking for sort of minimally invasive options from there. So once we move past the sort of behavioral medical options to treat BPH and LUTS, there's the surgical options, right? So these are the traditional procedures that have been performed for a long time by your urologist, the gold standard of which is TURP, or transurethral resection of your prostate. Essentially, this is a procedure that's done by placing a scope up through the urethra and physically removing part of the prostate gland. There's a lot of new procedures that urologists can offer. I encourage everyone to talk to your urologist, about all the options that are out there. But these are just some of the more minimally invasive ones: plasma vaporization, photoselective vaporization, radiofrequency, microwave, transurethral incision. These are sort of the newer procedures that are out there. Urolift is a common one that's available. And so, there certainly are a plethora of options for men out there that are having symptoms. All right. And so, shifting gears a little bit from the surgical side to what we're here to talk about this evening is PAE, or prostate artery embolization. All right. So this is a minimally invasive procedure, the goal of which is to decrease the blood supply to the prostate gland. All right. We're not eliminating the blood supply to the gland. We're not trying to kill the gland. Basically, we want to decrease the amount of blood coming into the gland, which over time will result in atrophy or shrinkage of the gland. In our case, it's fortunate that the gland is made up of a couple different types of tissue, but the type of tissue that surrounds the urethra seems to be most susceptible to this decreased blood supply. So when you perform the procedure, that tissue around the urethra atrophies the most or shrinks, and the urethra opens up, and then your urine can pass more easily out of the bladder. Again, just sort of to reiterate this with a sort of nice picture here, where you see the catheter in the prostatic artery, some tiny particles coming out. They get lodged in the gland, which closes those blood vessels down, resulting in ischemia or decreased blood supply. As a result of that, the gland shrinks, the urethra opens up, and you're able to pee more easily. All right. In terms of the pre-procedure workup, so I see all patients in clinic before I do these procedures. I require all patients to have some sort of imaging, which shows us the gland itself, be that a CAT scan or an MRI or an ultrasound. If you've had this done anytime in the past few years, we can get that imaging uploaded into our system, take a look at it. And that gives us a nice look at the anatomy of your pelvis in general. It's obviously important in terms of blood supply and planning the procedure of how we're going to get a catheter where we need to get it to treat the prostate gland. And also it's helpful to know how big your gland is before the procedure. All of our procedures are done either in a hospital or in a outpatient surgery center. with what we call moderate sedation. So I tell patients that's like twilight. So you'll come in, you'll put a hospital gown on, we'll put an IV in, we'll bring you back to the procedure room, which is again like this operating room, but has a big giant X-ray camera in it, like this picture you see here. This is our X-ray camera here. This is the table that you lay on. You can see some pictures in the background which display. I prefer doing all the procedures from the wrist or the radial artery. So again, this is a sort of drawing of putting a catheter into the artery in your wrist. So we'll numb up the skin in the artery in your wrist. We'll put that catheter in, and then we use our X-ray camera to guide our catheter down through the vessels into the pelvis, ultimately into the artery that takes blood to your prostate gland. The most important part of the procedure for me is to make sure that I'm treating your prostate gland and only your prostate gland. I don't want to treat your bowel. I don't want to treat your bladder. I don't want to treat your pelvic sidewall or anything else, just your prostate gland. So we're going to take some extra sets of pictures with our camera to ensure that our catheter is in the right place and that we're very confident that we're only treating your prostate gland. From there, we're going to perform what's called particle embolization. All right, just another picture here. So in this image, the catheter is actually going through the groin. I generally don't do that anymore. I do everything through the wrist. It makes the recovery process a little easier. You can get out of the procedure suite easier. You can get out of the hospital faster. You can get out of the outpatient surgery center faster. You're able to get up and walk around. So I generally reserve groin access at this point for someone who, for whatever reason, anatomically cannot have access through the wrist. And then we, like I said, we embolize with particles. So this is these are the particles we use. They're called embospheres. They are FDA approved for this procedure. There's 2 different sizes that we use, and we sort of make that determination once we're performing the procedure. And you can kind of see here this microscopic particles sort of layering out inside the syringe there, which are then injected and are what close down the blood vessel. So the procedure itself generally takes somewhere between 1 and 2 hours. After the procedure, you'll come back to our recovery area, where you'll hang out for about 2 hours after the procedure. Number one, we don't want you to have any bleeding from the wrist where we put the catheter in. And number two, we want you to be able to wake up from the sedation medicine that you get for the procedure. And number three, I just like everyone to be able to pass some urine in the recovery area. And as long as you're able to do that, we send you home the same day. I can't even remember the last time anyone had to stay overnight for the procedure. From there, we're going to schedule you for a follow-up phone call at 1 month, and again at 6 months. So the procedure itself, from a technical standpoint, in terms of getting the catheter where we want it and delivering the particles where we want them, is successful over 97% of the time, and that translates into essentially 80% clinical success, which I explain as 8 out of 10 guys who have this procedure done, their symptoms are going to improve from the procedure. Okay, and you can see here, all the data we have at this point is that if you are one of the 8 out of 10 guys that improve initially, that result should be long-term. The procedure itself's been around since 2010. So we have patients who are now approaching 10, 12, 13 years of follow-up, and generally we only use a small percentage of them. Their symptoms return. Usually it's a durable result. The other nice part about this procedure is the complication or side effect profile is very minimal. Knock on wood, I've never had a patient complain to me of urinary incontinence or sexual side effects after the procedure. There have been, the procedure has been studied extensively at this point. Numerous publications over the past 10 or 13 years, sort of, exploring various aspects of the procedure. We're not going to go into the details of all these, but just to sort of point out that this isn't just, something we're trying on folks. This is something that's been studied, has been looked at. It's successful, it's safe, it's effective. And it compares very well with surgical procedures. A little bit about my personal experience performing the procedure here at Johns Hopkins. I've been doing it since 2016, where we were part of one of the initial studies for the procedure. At that point, we were basically doing 1 or 2 patients a year, which has grown now to the point of doing, depending on the week, 5 or 10 patients. I've done over 200 procedures myself. It's extremely well tolerated. Patients are very happy to have it done. I think generally they've had a good experience. I've had minimal complications. Generally, the worst thing that happens after the procedure is for the first week or so, patients tell me they feel like their symptoms get worse. I chalk that up to sort of a low-grade prostatitis or inflammation of the prostate gland. Generally, that can be treated pretty easily with over-the-counter anti-inflammatory medications, which will knock it out in a couple of days and you'll be back to baseline. The biggest thing to remember about this procedure is that it takes time. It takes time for the gland to shrink. It takes time for the urethra to open up, and it takes time for your symptoms to improve. So, when I'm asked to compare this procedure with the surgical procedures, I find that patients generally fall into one of 2 camps. Patients who are miserable, they're ready for anything that can possibly help them, and they don't really care what it takes. I generally will advise those patients, probably surgery is a better option for them, one of the urologic procedures. But for patients who are not quite that miserable, looking for something more minimally invasive, more worried about side effects, that's where I think prostate artery embolization fits in very well. It's been extremely rewarding for me to perform the procedure. Patients are very thankful. And generally, the worst that happens is, unfortunately, some guys fall into that group of 2 out of 10 patients that just don't get better from the procedure. I think that, it's a procedure that's still finding its way into, a lot of practices around the country. And so, our hope here with this is to just, explain the procedure, maybe dispel some myths, and hopefully, bring some folks in and get the opportunity to at least discuss, what we're capable of offering. Just real quick before we get to the actual question and answer session, I get asked the same few questions over and over and over again. So I'm going to kind of run through those, then we can jump into the Q&A. So will I get a catheter of my urethra? No, I do not place a Foley catheter for this procedure. It's unnecessary at this point. We've done enough. Sometimes, earlier in our practice, we placed a Foley to help us define the anatomy. But at this point, we've done enough procedures that I no longer find that necessary. So no catheter needed for the procedure. What is the recovery like? So we talked about this a little bit. I find that maybe half, 2/3 of patients, experience a mild increase in symptoms for the first week or so after the procedure. Again, I think the gland itself just gets inflamed from having the particles injected. Generally, that can be treated with over-the-counter anti-inflammatories. And after about 5 to 7 days, you're sort of back to baseline. And then you can expect your symptoms to start to improve somewhere between 1 and 3 months after the procedure, which is why we generally schedule that first follow-up for 1 month. And then I schedule another follow-up for 6 months, where I find that that's sort of the plateau point. So once you've reached the 6-month post-procedure mark, where you are in terms of your symptoms at that point is where you can expect to be moving forward. How much will my gland shrink? I find that guys are very interested in the size of their prostate gland. You can expect your gland to shrink by about 25%. So it's a fairly modest overall decrease in size of the prostate gland. I do not repeat imaging. I don't get more ultrasounds. I don't get more CAT scans. I find it's unnecessary. I think what's the most important after the procedure is your symptoms. So, I've had patients where their gland shrank 50%, but they didn't really feel any better. And I've had patients where their gland didn't really change in size at all, but they felt much, much better after the procedure. And again, as we discussed sort of at the beginning here, is I think that has more to do with the part of the gland that the procedure is affecting rather than the overall size of the gland. And it's that tissue around the urethra. As long as we can get that to shrink and the urethra to open up, it doesn't matter about the whole size of the gland. We're just trying to focus on that area around the urethra, and that's why guys feel better afterwards. Does the procedure affect your PSA or prostate cancer? So in terms of PSA, your PSA is going to spike immensely after the procedure. So we don't advise anyone getting their PSA checked within 6 months of having their procedure done. In general, after 6 months, the PSA should return to its normal level. And as your gland shrinks, actually your PSA will be a little lower than before you started the procedure. As it relates to prostate cancer, there's no true consensus, right? We just haven't had enough patients that we've done the procedure in with prostate cancer to sort of make a true scientific conclusion on. Although sort of anecdotally at this point, we feel like it is safe to perform prostate embolization in patients who have a low-grade prostate cancer that's sort of in the observation phase. I've done it many times in my own practice. The procedure itself sort of grew in the setting of patients with bleeding after a prostate procedure or in the bleeding cancer, and physicians noticed that their urinary symptoms improved in that setting. And so that's sort of where some of this procedure itself came out of. The bottom line is we can't make any promises, but we do at this point feel like if you're sort of someone with a low-grade prostate cancer being observed, or maybe there's being worked up for prostate cancer, we can safely do this procedure. But certainly we're going to want to have you have close follow-up with the urologist and making sure that that is being monitored, while all this is happening. What about my current prostate medications? So, most of the patients, like I said, that I see are already taking medications to help with their BPH and their urinary symptoms. I advise all patients to continue taking these medications for at least the first month after the procedure. Once we have that follow-up, we'll sort of see how your symptoms are, and then we'll make some determinations between the 1 month and 6 month mark if we want to start maybe tapering some medications off, stopping medications, continuing medications. We'll sort of base that on what your symptoms are like, but you can expect for at least 1 month after the procedure to continue taking your medications. And I would say in most cases, guys are taking their medications for somewhere in the neighborhood of 3 to 6 months after the procedure. How does PAE compare with the surgical procedure? So we talked about this a little bit. There have actually been several randomized controlled trials comparing prostate artery embolization and what is considered the gold standard of surgical procedures, or TURP, or transurethral resection of the prostate. And basically, what these studies have shown is that when you look at the data objectively, so urine flow studies, residual urine left in the bladder, things like that, the surgical procedures are slightly better. But when you look at subjective measures, like how the patients feel after the procedure, they're actually equivalent. So the PAE is equivalent to TURP. And when you compare things like side effects, complications, days in the hospital, that favors prostate artery embolization. So, these studies have been very helpful in showing that PAE essentially compares very well with the surgical procedures that are available at this time. And I always encourage everyone to discuss all the options. The most important part as a patient is that you make an informed decision, you have all the information, and decide the procedure that's right for you. Lastly, is the procedure covered by insurance? Yes, it is. Medicare covers the procedure. Most insurance companies cover the procedure. The only company I've had issues with recently is United Healthcare, who still considers the procedure experimental. Based sort of case-by-case basis. We've had some patients where we're able to speak with their insurance company and get the procedure covered. In other cases, we have not. But otherwise, 95% of the time, this procedure is covered. So that sort of brings us to the end of the webinar here, the presentation part of things. If you have questions, if you just want to come talk about it, I'm happy to meet with anyone about this procedure. I love talking about it. I love doing the procedure. I love seeing patients. Give us a call, check us out on the web. It's definitely worth a conversation. Again, this is sort of back to the end here. At this point, I'm going to turn it over to the Q&A, and I am happy to answer any questions that we have. Looks like the first question here is, I heard I may experience post-PAE syndrome. Can you explain what this is? So post-PA syndrome is basically the term for that first 5 to 7 days after the procedure. It's post-embolization syndrome is sort of the more generic term for it. It happens anytime you do this procedure, anytime you inject these particles to close down blood vessels in any part of the body, you can experience this. In the prostate, like I said, it sort of results in a prostatitis or inflammation of the gland, which can result in worsening of your symptoms. The other thing that some guys will tell me they experience is just sort of a general feeling like not great, like tired, fatigued. They might run a low-grade fever, just kind of feel crummy for a few days. Every once in a while, patients will tell me they have some burning with urination, some pain in the pelvis, things like that. But these are all sort of fall into this term of post-PAE syndrome. And it happens, like I said, in about 50%, maybe 2/3 of guys. And it's self-limited, usually gets better with over-the-counter anti-inflammatories. And within a week or so, that will go away. The next question is, will symptoms improve or get worse over time? So as it relates to the procedure itself, generally there's going to be a lag time after the procedure, so you can expect 1 to 3 months of no real change. Somewhere between 1 and 3 months after the procedure, your symptoms should improve, and then that's kind of a gradual improvement. And I find that once you sort of get to the 6-month mark, that gradual improvement plateaus, and you won't really see too much further improvement at that point. So where you are at 6 months is where you can expect to be for the long term moving forward. It is possible at that point that symptoms worsen in the future. If that is the case, in patients who get improvement from the procedure but gradually have worsening over time, I do offer repeat procedure to them. Generally, the gland has somehow started to regenerate some blood flow, and a lot of times we're able to go in and treat that new blood flow, and then they can get further improvement from that. Is this the same as a green light laser? So no, this is not the same as a green light laser. Green light laser is a procedure that's performed by your urologist with the scope going up through the urethra to decrease the amount of tissue around the prostate gland. Whereas again, this procedure, we go in through the blood vessels and decrease the blood flow coming into the prostate gland. Can people that have had prostate radiation have this performed? Absolutely. There are very few situations that disqualify you from having this procedure done. So I encourage everyone to come in, have a consultation. As long as you have, we'll get some imaging done. We'll make sure the anatomy looks favorable. Patients who've had surgery before are still candidates for the procedure. Patients who've had radiation before are still candidates for the procedure. There's, like I said, very few things that disqualify you. So I encourage everyone to seek consultation. All right, if PAE is no longer helpful, can it be done again, or would you do a TURP? All right, great question. So I look at this, I basically divide these patients into 2 groups. So if you have a prostate artery embolization done, and you get absolutely no improvement from it. So we do the procedure, we see you back at 1 month, we see you back at 6 months, and you're like, hey, Brian, my symptoms are exactly the same as before I had this procedure done. And I consider that a procedural failure. It just didn't work. And I don't see any point in repeating that procedure. On the flip side, if you're someone who has the procedure done, you get better, and let's say 2 years later, your symptoms start coming back again, then I think it is worthwhile to repeat the procedure. I think you've, in my mind, that's someone who benefited from the procedure. At some point, the gland somehow, got increased blood supply again. And so there's certainly a chance for us to go back in, decrease the blood supply, and see further symptomatic improvement at that point. Can you perform this procedure if the patient has had a TURP or TULIP previously? Absolutely. Like I said, prior radiation, prior surgery, none of these things disqualify you from having the procedure. I have treated many, many patients who've had any flavor, UroLift, green light, TURP, to all the procedures. I've treated them with prostate artery embolization, and it does not affect your, you still fall into that category of 80% chance of improving from the procedure. Another thing I think we should talk about is patients who fail prostate artery embolization. You are not disqualified from having any of the surgical procedures. You can still have a TURP, you can still have a UroLift, you can still have any of those procedures after the embolization procedure. In fact, I've talked to some urologists who say that they feel like the patients who have had a prostate embolization prior to a surgical intervention have less bleeding because there's less blood flow coming into the gland. So it really, either way, you can go. All right. Are there cases where the procedure made somewhere outside of Johns Hopkins needs to be repeated if the results did not reach expected results? All right. I have seen a handful of patients who have had a prostate embolization elsewhere, and I sort of treat them the same as if I had done it myself, where if you've had a prostate embolization and you got no benefit from it, I don't really see a whole lot of benefit of trying it again. But if you had a prostate embolization and you got benefit from it, but your symptoms have returned, I'm happy to repeat it, whether I did it or someone else did it. I guess there could be a potential rare instance where something went wrong with the procedure, you just didn't feel like it was done properly, and but that would be kind of more of a one-off situation where we'd have to discuss it, and again, certainly worth a consultation. I'm happy to talk to anyone about any of these issues related to prostate embolization. Should patients with elevated PSA see a urologist and get all of the workup for the elevated PSA to rule out cancer prior to prostate artery embolization? Absolutely. So in patients who have an elevated PSA, I always require them to get worked up with a urologist to exclude cancer. Obviously, one of the potential treatments, if you do have prostate cancer, is having your prostate removed, which also results in improvement of your symptoms of an enlarged prostate gland. So I just like to make sure that everyone is at a proper workup for an elevated PSA prior to performing any procedure. I think that's just a more sound way to go about it. All right. My father seems to have a lot of these symptoms. He's in his early 60s. It will be very difficult to get an appointment based on pride and embarrassment. Any tips for talking points outside of improvement in quality of life? Example, putting off could lead to. So this is, I actually see a lot of patients like this. Usually it's the wife making the husband come in for the procedure. But yeah, I think that, symptoms are going to continue to progress. BPH is not going to go away on its own. If medications aren't working, and they're not really willing to consider a surgical procedure, then this is a great option. It's minimally invasive. There's no catheter going up the urethra. There's no scope going up the urethra. It's a catheter in the wrist. I certainly understand the embarrassment aspect of it, but it's a situation that's only going to progress. And you really do want to avoid the situation where you end up with a catheter up the urethra permanently, which I see patients like that too. And so, my advice to guys is, again, it's worth the conversation. You don't have to do the procedure, but, having the conversation is not going to hurt anything. Risks with patient with atherosclerosis or diabetes. All right, great question. Atherosclerosis and diabetes do not exclude you from having the procedure done. However, in patients who have significant atherosclerotic disease, it makes my job more challenging. The handful of patients that I have not been able to successfully get the catheter where I need it to go was due to atherosclerosis. So if your vessels are very calcified, it's very hard to get our catheter into the prostatic artery. If we can't get the catheter into the prostatic artery, we can't do the procedure. So there's not necessarily increased risk of having the procedure done if you have atherosclerosis or diabetes. It's that you have increased risk of a technical failure, meaning I just can't get the catheter where I need it to go. For scheduling purposes, should we ask for you by name or say keywords like PAE? Absolutely. You can PA if you say PAE, if you say BPH, if you say urinary symptoms, if you say my name, it's all going to end up coming to the same sort of clinic which I manage, and we'll make sure we get you to the right place. What kind of follow-up care is typical and who manages it? So I will see you 1 month and 6 months after the procedure. During those 6 months, we'll talk about managing things like medication, symptoms, things like that. I encourage everyone to continue following up with their urologist. There's no reason you need to stop seeing a urologist. I don't want to take over your urologist's care or anything like that. We're going to work together in parallel. And again, for those 20% of patients that don't improve from the procedure, you could still need your urologist down the road for a surgical procedure. How do you measure urine flow? So typically this is done in your urologist office, where they have a machine which can do many things. It can measure the amount of urine in your bladder before you urinate, after you urinate. It can measure how long it takes you to urinate, how much urine comes out, determining flow and things like that. We effectively refer to these as urine flow studies, which give us a lot of information about is it the bladder that's dysfunctional? Is it the prostate gland that's obstructing the flow? And it helps us guide treatment in that way. What are the risks and benefits of watchful waiting? Excellent. So if you remember back to the beginning, typically the rule of BPH is a third, a third, a third. So a third of patients are going to stay the same. A third of the patients are going to spontaneously get better on their own, and a third of patients are going to get worse. So there is, certainly, it's not something you don't need to jump into having a procedure done the minute you feel like, you're having symptoms worsening. I would say the majority of patients that I see have had symptoms on that magnitude of years, if not decades, it's just something very a personal decision. When you feel like the symptoms are having a significant impact on your life, then that's when you should seek treatment. If it is found that I have atherosclerosis, is there treatment? So if you have atherosclerosis, you certainly, like I said, it does not disqualify you from having the procedure done. It just makes it more technically challenging. Now, if you're someone who has a exceedingly overwhelming amount of atherosclerosis, I may just tell you like, hey, this isn't even worth trying. But that is, I can probably only think of 1 or 2 times I've ever had to tell a patient that. So even if you have atherosclerosis, again, it's worth coming in and have a conversation. I'll be very honest with you. I'll be very upfront with you about your chances of success. And if I think this is something we can do, but it would be very, very, very rare that you have so much atherosclerotic disease that we can't treat you. Any risk of arterial embolism or thrombus? So I've learned over the years to never say never. All right. So anytime we do a procedure, anytime we're, putting a needle or a wire or a catheter or anything into the body, the risk is not zero. So there is always a risk of arterial injury or thrombus or embolism. Again, in whatever 7 or 8 years of doing this procedure, it's not anything I've experienced, but I've certainly heard of it happening. Colleagues around the country, the risk is very, very low. Unfortunately, it is not zero. What post-procedure medications will I be given? I do not routinely give anyone post-procedure medications other than to restart all of your pre-procedure medications. I encourage guys to have a low threshold to start anti-inflammatory medications or NSAIDs or things like Motrin, Advil, Aleve. If they feel like their symptoms are starting to get worse after the procedure, but I don't make everyone do it. In the rare instance of a urinary tract infection after the procedure, we may start some antibiotics, but again, that's been exceedingly rare, and we do that on a case-by-case basis. If I have not seen a urologist for my BPH, should I do that first? Not necessarily. I think if you have a primary care physician who's been managing your symptoms and checking your PSA, and you're happy with that care, you don't necessarily need to see a urologist. Depending on the conversation that we have, you may want to see a urologist after that to just to kind of see what the surgical options are. That's completely up to you, but I don't mandate it. It's not something you have to do. How long does it take to schedule an appointment with me? If you call, generally, we can get you into clinic to have a discussion about the procedure within, I would say, 4 to 6 weeks. And from that point, we can probably schedule a procedure within a month. So, all told, 1 or 2 months, something like that. Are there medications known to trigger or worsen BPH? Not to my knowledge. I think that any hormonal medications, the prostate gland is responsive to hormones, so any testosterone, things like that, are generally going to result in some enlargement of the gland. There's medications which block that to try to shrink the gland, but by and large, any medication that you're on is not really going to have any effect on the prostate gland itself. If I have not tried drug therapy first, is that okay? It's okay. I'm going to have a very honest conversation with you and probably recommend a trial of medication. It's not something you have to do for years before we can do the procedure, but I think, a few months of medication is probably a worthwhile trial prior to a intervention. It's minimally, the only thing less invasive than this procedure is medication. And so I generally encourage all patients to try it first. I'm not going to make you do it. Your insurance company might make you do it, but I'm not going to make you do it. And, we'll sort of help you and follow you through that time. Are there any other pre-existing conditions that would make me not a candidate for this procedure? Off the top of my head, there's nothing that I can think of. I'm sure, on a case-by-case basis, again, there may be something that comes along that may prevent someone from doing it, but that would be very rare. And again, it's always worth a conversation. What age is too young to be experiencing BPH? I would say the youngest patient I've treated is 40. Not that you couldn't have BPH younger than that. I just have never treated anyone younger than that. So I think it's just a matter of, getting evaluated, getting worked up, having all the proper studies done. And if it turns out that, you're young and you have BPH and it's causing symptoms, there is no age cutoff for the procedure. Last question. I have high blood pressure and I'm on medication. Is that a problem? Absolutely not. I would say the majority of patients that I treat are on medications for various, medical conditions, high blood pressure being one of the most common. And, we'll work with it, and this should have no effect on your blood pressure. If anything, hopefully the stress of waking up in the middle of the night or having to go all the time will lower your blood pressure. Thanks again, everyone, for joining. If you're interested in scheduling an appointment, please give us a call. Look forward to meeting everyone.